good morning to all the participants. And in this particular session, we will have the discussion on Caesarean section in bovines with particular reference to different surgical approaches. Now, all of you know that the C-section, it is one of the oldest surgical interventions in the field of veterinary science. And it is widely or it is commonly used as a emergency procedure for the surgical delivery of the calf or fetus. If you'll see, the generally this C-section in bovines, it is indicated when the obstetrical techniques fail to deliver the fetus. In that condition, we have to go for the C-section to save the life of the mother, as well as the if fetus is live, then to save the life of the fetus. And also, we are trying to preserve the future reproductive efficiency of the mother. So C-section. So next, just a minute. So a C-section, if you see the literal meaning of the C-section, it is nothing. It is the surgical delivery of calf or fetus. And generally, this C-section it involves two important procedures that we are performing during the C-section. First is the laparotomy or ciliotomy. That is nothing. That is the surgical opening of the abdominal cavity. And the second procedure that we are performing, that is the hysterotomy. And again, this is nothing. This is the surgical opening of the uterus. And after opening of the uterus, we are removing the fetus. Now, the C-section, this procedure is necessary when there is problem in the normal vaginal delivery, or it is not progressing in the normal time period. In that condition, we have to immediately go for the C-section for saving the life of the mother as well as the fetus. Now come to the indications. If you see the objectives of C-section or goals that we want to achieve during the C-section. So we are trying to save the life of the cow or buffalo. Second objective during the C-section, if the fetus is live, in that condition, we are trying to save the fetus. And third, that is very important in the dairy animals or productive animals or livestock animals, that is the preservation of future reproductive efficiency. That is very, very important. Because my dear friends, all of you know that nowadays people are taking this dairy activity as an economic activity. They are trying to generate income from this dairy activity. And it is already established that for the profitable dairy business, every year the owner should get one calf. So when he will get calf, then we can able to preserve the future reproductive efficiency of the animal. So that is with these three goals we are trying to achieve during the C-section procedure. Now come to the, depending upon the health status of the cow or fetus, Newman and Anderson, they have classified this C-section into the three categories, like elective, first one, elective C-section. That is rarely we are going for this elective C-section in our country. In most of the time in our country, in India, we are going for the emergency C-sections only. But in European world, most of the time they are going for the, many times they are going for the elective surgery also. But in our place, mostly we are going for the emergency C-section. Now in emergency C-section, again we are having two types. First is emergency C-section with non-emphysematous fetus, and another one, emergency C-section with an emphysematous fetus. Now in all these three, the expected outcome or anticipated complications are dramatically differs in all these three different conditions. Okay, if you go for elective, there will be outcome will be very excellent. emergency surgery, C-section, if you will perform, definitely there will be some intraoperative or post-operative complications and problems will be there. You will face the problems. Okay, so the outcome will be differs significantly in all the three conditions. Now come to the indications of for the C-section. When we are going for the C-section, so these are the indications. First is the feto-maternal disproportion, either it may be relative or absolute. Second is if there is incomplete dilatation of the cervix, vagina or vulva, in that condition, you have to go for the C-section. In case of irreducible uterine torsion, you have to refer the case for the C-section. In case of inability to correct the fetal maldisposition, this is also a common problem that leads to dystocia. In that condition also you have to go for the C-section. If there is inability to perform fetotomy on an emphysematous calf, in that condition also you may need to perform the C-section. And lastly, if there is inability to perform fetotomy on fetal monsters, in that condition also you have to go for the C-section. Now, cesarean section, further you can classify on the basis of the problem or issue associated with the mother or the fetus. You can classify this indication in two categories, fetal indications and the maternal indications. Under this maternal indications, the immature heifer, in that condition, you may go for the C-section. If there is any pelvic deformity, like pelvic fracture or any congenital deformity, in that condition, you have to go for the C-section. If there is failure of cervical dilatation, in that condition, C-section may be required. In case of uncorrectable uterine torsion, hydrops, uterine tears, in these conditions are associated with the mother or dam. So in these conditions, you may opt for the C-section. Now, fetal related, if there is absolute fetal oversize, in that condition, you have to go for the C-section. If there is malposition of the fetus, then you may opt for C-section. In case of fetal anasarca, that is the ascites of the fetus, in that condition also you may go for C-section. Emphysematous fetus, prolonged gestation, mummification. And the last one, this some congenital malformation of the fetus, that is the cystosomous reflexes. In that condition also you may opt for the cesarean section. So these are the some important indications. Under these indications you may go for C-section. Now come to the case selection or surgical judgment. It is very important because nowadays honors are also highly aware, and you have to clearly communicate the outcome of this procedure to the honor of the animal. So the C-section is, if you will see, it is three factors are very important on which the outcome of the C-section depends. So first one is the duration of dystocia. This is very, very important factor, and the outcome of your C-section is inversely related to the duration of dystocia. That means if the duration of dystocia is more, or it is lengthy, duration is more, that will decreases your C-section outcome. Your outcome will be poor. So we have to try to decide. That means here you have to take the decision. Gynecologist handling that particular case, he has to take immediate firm decision, concrete decision that this animal, this case must go for the C-section, or this case can be, fetus can be taken out, fetus can be delivered by obstetrical techniques. So this decision is very important for the reducing the duration of dystocia. Now, second important factor on which the outcome depends, C-section outcome depends, is the extent of manipulation. If you have manipulated, previous manipulation is more, in that condition, the outcome will be poor. So again, the C-section outcome is inversely related to the extent of manipulation. There should be minimum manipulation. Okay, so these two factors are very important that governs the outcome of the C-section. Now, third factor, the condition of the cow at the time of surgery. As we are doing, we are analyzing the pre-operative assessment of any surgical patient is very important. So similarly, in C-section, you have to go for the pre-operative assessment of the animal. All the important clinical parameters you have to record, and accordingly, if there is any disturbances, you have to correct before going for the surgery for getting the excellent outcome of the C-section. Now, if in case of already in case you are going for the elective C-section, so that condition, the intraoperative as well as postoperative complications will be rare. But if you are going for the emergency C-section, definitely you will encounter some intraoperative as well as postoperative complications. So the ideal emergency case in which you can go for the C-section is a cow that has been in labor briefly with a live calf, and quick decision for the C-section. This is very, very important factor, quick decision. Okay, so person who is handling this case, dystocia case, he must able to analyze, he must able to arrive on a concrete decision for the whether this condition may be relieved normally or this case may go for the C-section. This is very important for the excellent outcome of the C-section. Now, one another criteria, this is for the doctors or clinicians who is handling the dystocia cases. If you unable to palpate the front legs as well as head, if you unable to manipulate into the birth canal, then the decision to perform C-section you should take immediately. You should immediately refer the case for the C-section. Because in Punjab, Mr. Dhinsda et al. In 2019, they have reported that post-Caesarean survivability and future fertility may be improved if the surgery is performed within 12 hours of the onset of dystocia. So within 12 hours, you have to take the decision whether this animal will go for C-section or you may opt for the obstetrical techniques for the expulsion or for the delivery of the fetus. Because as you delay the case, as the duration of the dystocia will become more, is more, in that condition, there may be chances of cow becomes toxic, pyrexic, hypotensive, and that leads to risk of abdominal contamination during the surgery, and your ultimate outcome will be very, very poor. Now, if you see in tabular form, the main factors affecting the overall outcome for the C-section. So cow and calf-based risk factors are health of the cow at the initiation of the surgery. That is very important. You have to analyze, you have to take all the clinical data of the animal. Now, second is the fetus is live. In that condition, live fetus, that condition, your outcome will be better or excellent. If the fetus is dead or in physematous, then there will be risky. Okay. Now, sex of the fetus, it is noticed, it is found that if the female fetus, if the sex of fetus is female, so in case of female, the survival rate will be more. If age and parity of the animal, primiparous animal, survival rate is more. Again, the duration of dystocia, I have already told you, duration, if you increase the duration of dystocia, then your result will be poor. Then temperament of the dam, this is also one factor on which the outcome depends. Now, second, surgeons and surgical best risk factors, elective or emergency surgery. Now, second is the ability to exteriorize the uterus. This is very important for the survival of the dam. If you can effectively or you can able to exteriorize normally the gravid uterus from the abdominal cavity during the C-section, then chances of survival of the dam will be more. Now, surgical time, that plays also very important role in the survival of the dam. If you are increasing the surgical time more than 1 hour, then chances of survival will be decreases accordingly. Now, surgeon's skills and experience also, hygiene of the surgeon and surgical environment, a removal of abdominal blood clots, that will also increase the survival rate of the dam, and degree of perioperative obstetric manipulation. If there is more manipulation, the chances of survival will be less. If less manipulation, the chances of survival will be more. Now come to the surgical approaches for C-section. You can broadly classify this surgical approaches into the two categories. You may perform this surgery either in the standing approach or either following this recumbent approach. And in our country, we are mostly we are following the recumbent approach because most of the time in our country, India, we are performing this C-section in dystocia cases, and we are performing as an emergency procedure. So this standing approach is indicated for the elective C-section. Okay, if everything is normal, fetus is live, in that condition you may opt for the standing approach. But as I have told you during the start of this, during the beginning of my presentation, that elective surgery were rarely performed in our country. Most of the time we are performing the C-section as an emergency procedure. Now, if you see the recumbent approach, in recumbent approach, you can easily able to exteriorize the gravid uterus from the abdominal cavity. Okay, so this is the benefit of this recumbent approach. And if you can able to exteriorize the gravid uterus from the abdominal cavity, that means you are reducing the chances, there will be decreased chances of abdominal contamination. So there will be less chances of peritonitis. So the recumbent approach can be either midline or directly over the pregnant heart, or it may be paramedian. You may follow a recumbent approach. Now, a standing approach. For the standing approach, you may approach either through the left paralumbar fossa or you may approach for the right paralumbar fossa. But most commonly opted approach in a standing approach is the left approach, is the commonly followed approach for the standing C-section, because the rumen on the left side, it prevents the evisceration of a small intestine. And because of this prevention of evisceration of a small intestine, it will facilitate you easy exteriorization of this gravid uterus from the abdominal incision. But sometimes in a standing approach, there may be chances of this ruminal prolapse due to the excessive straining. And to minimize this straining, you may go for the caudal analgesia. You may administer caudal analgesia. Now, so overall, if you will see the surgical approaches, whether it is standing or recumbent, total of 8 approaches are there for the C-section. First one, the standing left paralumbar ciliotomy. Second is a standing right paralumbar ciliotomy. Third is recumbent left paralumbar ciliotomy. Again, recumbent right paralumbar ciliotomy. Fifth is recumbent ventral midline ciliotomy. And sixth is recumbent ventral paramedian ciliotomy. Seventh, ventrolateral ciliotomy. And lastly, the standing left oblique ciliotomy. And out of these 8 approaches, as I have told you, the most commonly followed approach in our place or at our place in our country is the recumbent ventral paramedian ciliotomy. This is the commonly followed approach at our place. Now, the standing one by one, we will see. First approach is the standing left paralumbar ciliotomy approach, and most commonly used approach in case of uncomplicated, if you are going to perform as an elective Caesarean section, or in cases of uncomplicated Caesarean section, you may follow, that is the standing left paralumbar ciliotomy. And your skin incision, laparotomy incision, you have to place in the left paralumbar fossa, just 10 centimeters below the transverse process of the lumbar vertebra. Now, I hope all of you know the different anatomical structures you will encounter when you will enter inside the abdominal cavity through this left paralumbar fossa. And you already know that is the skin, oblique muscles, then the transverse muscle, then peritoneum, and thereafter you will enter inside the abdominal cavity. So after opening of the abdominal cavity, then you have to exteriorize the uterus. Now, the contraindications for this procedure include the inability of the patient to stand throughout the procedure. Sometimes patients are very weak. Patients are exhausted. In that condition, if you will opt for this standing left paralumbar ciliotomy approach, then during the procedure, you may see animal will fall down or animal will become recumbent. So that may, during the procedure, during your surgical procedure, if animal becomes recumbent, that may lead to the contamination of the abdominal cavity. So if the animal unable to stand, then in that condition, you should not opt for this standing approach. Another problem you may encounter if you are following this standing left paralumbar ciliotomy approach, there may be difficulty in exteriorizing the uterus, gravid uterus from the abdominal incision. Now, next approach is a standing right paralumbar ciliotomy approach, and this approach has all the indications and contraindications of the left paralumbar approach. But only difference is that if you follow this right paralumbar ciliotomy approach, there may be evisceration of the intestinal loops, and due to that evisceration, that may lead to the problem in exteriorization of the gravid uterus from the abdominal cavity or abdominal incision. So this standing right paralumbar ciliotomy approach is only useful when you can able to palpate a large calf in the right horn. In that condition only, if you can opt this approach, standing right paralumbar ciliotomy approach. And other indication for this standing right paralumbar approach in cases of hydrotic conditions of the uterus, in that condition also you may opt for this standing right paralumbar ciliotomy approach. Now, recumbent left paralumbar ciliotomy, this is again recumbent left paralumbar ciliotomy approach. This approach, if you are following this approach, in that approach there may be difficulty in the exteriorization of uterus, and closure of the abdominal wall incision will be difficult. That may be difficult, and this may be due to the increased tension on the muscular layer. So these are some contraindications, or these are some problems you may face if you are following this left paralumbar ciliotomy approach. Similarly, this recumbent right paralumbar ciliotomy approach, this is rarely followed in clinical cases, and similar to recumbent left paralumbar approach, and complications of not having the lumen to retain the abdominal viscera, as I have told you in the previous slide. Now, next one is the recumbent ventral midline ciliotomy approach, and you already know, if you are following the ventral midline ciliotomy approach, the different anatomical structures that you may encounter are the skin, subcutaneous tissue, and the linea alba. And here, if you are following this recumbent ventral midline ciliotomy approach, you may require additional assistance for the restraining of the animal on the dorsal recumbency. You have to place the animal in the dorsal recumbency, and slightly you have to tilt the animal approximately at the 45-degree angle towards the surgeon, so that surgeon can, after opening the abdominal cavity, surgeon can easily able to exteriorize the gravid uterus. Otherwise, there may be, if you are not tilting the animal from the exactly dorsal position, there may be difficulty in the taking out or exteriorization of uterus from the abdominal cavity. Now, the complications of this approach, recumbent ventral midline approach, you may feel, if you will, due to the improper closure of the abdominal incision, there may be development of abdominal wall herniation, or in severe cases, there may be evisceration of abdominal contents that may lead to the incisional hernia. And also, the merit of this approach, you can easily exteriorize the uterus. That is the main benefit or merit of this ventral midline, recumbent ventral midline approach. Now, next is, this is the diagram indicating the ventral midline approach, how we have to restrain the animal during the procedure. This is the ventral midline incision, and just slight lateral, 5-10 centimeter lateral from the midline. If you are putting the incision, then this is the paramedian approach, ventral paramedian approach for the C-section. So recumbent ventral paramedian ciliotomy, this is again similar to the ventral midline approach in most respects, including the advantages and contraindications. Now next is this ventrolateral ciliotomy. Ventrolateral ciliotomy, one benefit is there that you can easily, if the order of the cow is very large, in that condition you can easily, if required, you can easily extend your incision in the caudal direction for the easy exteriorization of the gravid uterus. So the only benefit of this technique is easy exteriorization of the gravid uterus, and you can extend the abdominal incision as per your requirement. But the problem in this technique, again, there will be problem in the closure of the abdominal incision. Now, ventrolateral ciliotomy, this approach readily permits the exteriorization of uterus and making it suitable for the removal of the large emphysematous fetus. In that condition, you may follow the ventrolateral ciliotomy approach. And incision is easily extended caudally than when the ventral midline or ventral paramedian incision used. Now, ventrolateral again ciliotomy, the closure of this incision is often more difficult, as I have already told you. There will be difficulty in the closure of the abdominal incision. Now, standing left oblique incision, again you can see this is the standing left oblique incision, and this incision, the incision starts from the 4 to 6 centimeter ventral and cranial to the tuber cocci and extends cranioventrally at the 50-degree angle to the ground. And this incision extends further cranially or more ventrally than the traditional left paralumbar incision. So again here the merit is that, benefit is that you can able to extend the abdominal incision as per your requirement. Now come to this anesthesia or restraining for the C-section. If you are going for the standing approach for performing the C-section, then might be you require some anesthesia or sedation for the restraining the animal. So we are having the different drugs for the restraining, and different combinations are there. So for a standing sedation, you may use xylazine 2%, and if you are using only xylazine 2%, the dose rate you may use 0.075 to 0.2 ml intramuscular route for 100 kg body weight. And if you are using this, sometimes you may also go for the administration of xylazine or lidocaine epidural analgesia. In this condition, you may use xylazine at the dose rate of 0.25 to 0.5 ml per 300 kg body weight, and you have to make 5 ml solution with the local anesthetic solution, and then you have to inject in the epidural space. Now again, you can use the IV stents for the standing anesthesia, standing C-section. For the IV stent, you can use the combination of butorphanol, xylazine, and ketamine, and the dose rate is 0.2 to 1 ml for 100 milligram per kg, 100 ml per 100 kg body weight of the animal. You can use the butorphanol. Xylazine, you can use 0.1 to 0.15 ml for 100 kg body weight, and ketamine you can use 0.05 to 0.1 ml per kg body weight. Similarly, we are having this combination you can inject into through the subcutaneous route or intramuscular route, and the ratio of combination of butorphanol, xylazine that you may use, that is the 1:2:4 ratio. In this ratio, you may mix these three drugs, butorphanol, xylazine, and ketamine, and you may administer into the animal through either subcutaneous or intramuscular route. So these are some different combinations that you may use for the standing C-section. Now again come to the recumbent surgery. Suppose you have opted for the recumbent C-section. You are following the recumbent surgical approach. In that condition, again, little bit variation is there, anesthetic variation is there. If you are using the only xylazine, then 1 ml you have to inject through intramuscular route for 100 kg body weight. And if you are using the xylazine and ketamine combination, then you may inject xylazine at the dose rate of 0.25 ml for 100 kg body weight intramuscular route, and 4 ml ketamine for 100 kg body weight through intramuscular route. Similarly, we are having this butorphanol, xylazine, and ketamine combination for the IV route and for subcutaneous and intramuscular route. So these are the different combinations that you may follow for the recumbent C-section. Now, in anesthesia and restraint, suppose you are using for this butorphanol. So the withdrawal period for the butorphanol in cattle is 28 days in meat and 7 days in milk. But for in our country, this milk is very important. So if you are using the butorphanol for the sedation or for the anesthesia, you are using this butorphanol protocol. In that condition, you have to give a specific instruction to the owner of the animal that the milk should not be used for 7 days. Okay, milk is not meant for human consumption for the at least for the 7 days. Another problem, however, this xylazine we are regularly using, but you may feel if the animal is not cooperating in that condition, you have to inject the xylazine, but it increases the tone of the uterine tone, and this will lead to the problem, or this will interfere in the exteriorization of gravid uterus. So if possible, just you go for the exteriorization up to the exteriorization of uterus and extraction of fetus, you just simply go for the local analgesia. You can infiltrate the local anesthetic agent either following the L block or line block. Okay, and then thereafter, if required, you may go for the sedation. But if it is not possible, then you don't have any option. Then you have to go for injecting this xylazine hydrochloride. Now come to the surgical technique. As I have told you, this C-section in bovines, this includes two important procedures. The first is the laparotomy or ciliatomy. And once you have decided your surgical approach, then through that particular approach, first of all, you have to perform the laparotomy or ciliatomy, that is the surgical opening of the abdominal cavity. And after opening the abdominal cavity, then you have to go for the identification of the gravid uterus. That is very important. Sometimes people confused with the rumen, because rumen is filled with the ingesta. You may confuse with that this rumen is confused with the uterus. So you have to identify clearly that this is the uterus, gravid uterus, and then you have to exteriorize the uterus from the abdominal incision. Now, after exteriorizing the uterus from the abdominal incision, you have to put the hysterotomy incision, or you have to put the incision over the uterus. And incision over the uterus, you have to put along the greater curvature of the uterus. And just during the incising the uterus, you have to avoid the major blood vessels and caruncles. Okay. So you have to put sufficiently large hysterotomy incision. Okay, so that you can easily extract or take out or easily you can take out the fetus. Otherwise, if you put the smaller incision, uterine incision, that may lead to the tear of the uterine wall during the extraction of the fetus. And once tearing occurs, then repair of this uterine incision, it becomes very difficult. And sometimes the tear of the uterus becomes so longer, so we are unable to close the uterine tear. So such problems may arise. So you have to put sufficiently large uterine incision so that you can easily able to take out or extract the fetus from the uterus. Now, ideally, you have to prevent, as far as possible, you have to prevent the leakage of the uterine contents into the abdominal cavity, because this may lead to a severe problem, contamination of the abdominal cavity, and that may lead to the development of peritonitis. So as far as possible, during the surgical procedures, you should prevent the leakage of the uterine content into the abdominal cavity. And thereafter, you have to go for the removal of the fetus from the uterus. Once you have removed the fetus from the uterus, then you have to remove the placenta. If the placenta, you can easily able to detach the placenta from the crankles, then you have to take it out. Or otherwise, if you are unable to remove it, then simply you have to trim the portion that is hanging outside the uterus and then leave other part as such. Okay. Now, next thing, the closure of the hysterotomy incision. Normally, in our condition, as I have told you repeatedly, that we are mostly performing in the this C-section as an emergency procedure, and as we are performing as an emergency procedure, most of the time the uterus is compromised. So, in that condition, you have to follow two-layer closure is recommended for the uterus. But if uterus is healthy, you may go for the only single layer. But uterus is mostly we are following double layer closure of the hysterotomy incision. And for the closure of the uterotomy incision, you have to follow the continuous inverting pattern. And during this closure of the uterine incision, this is very important. You have to invert your sutures. Your sutures should not be exposed. Your knots of the sutures should not remain exposed, because if your sutures or knots of the sutures remains exposed, that will provoke or that will aggravate the adhesion formation in the post-operative period. And if there is severe adhesion formation, that may lead to compromise in the future reproductive efficiency of the animal. So, my dear friends, you must, during the repair of this uterus, you must take care to invert all the sutures, especially the suture knots, okay, for the effective closure of the uterine incision. Second thing, during the closure, after closure, is the blood clots. If there is any blood clot, you have to gently wash it out, or you have to irrigate it so that there should not be any blood clots. Because these blood clots, again, it initiates or provokes the adhesion formation in the post-operative period. And again, this may adversely affect the future fertility of the animal. Now, as far as possible, you should not use the gauze sponge to wipe the uterus. Okay, because that may lead to the serosal aberrations and which may cause uterine adhesions. So you try to avoid this gauze sponges to wipe the uterus during the surgical procedure. Now, if possible during the, however, practically most of the time it is not possible, but if possible, just you try to examine or visualize the ovarian bursa also, because if blood clots are there on the ovarian bursa, then that will lead to the severe adhesion formation, and that adversely affect the future fertility efficiency of the animal. So this is also very, very important step. If you can able to visualize, if you can able to examine the ovarian bursa during the surgical procedure, you must examine and you must remove whatever the blood clots are there for the prevention of the post-operative abdominal incision. Now, after rinsing the uterus with the isotonic fluid, then you have to replace it into the abdominal cavity. And according to literature, I have found that if you will instill into the abdominal cavity the combination of heparin and antibiotic and NSS normal saline solution into the abdominal cavity for the abdominal lavage. So this will add to reduce the adhesion formation, so that you can you can be able to achieve your C-section goal, that is the preservation of future reproductive efficiency of the animal. Now, lastly, you have to go for the abdominal wall closure. You have to close the abdominal incision in 2 or 3 layers. Now, come to the post-operative care. You can see in post-operative care, routinely you have to advise for the antibiotic therapy for 5 to 7 days. And then analgesics, however, commonly we are using the meloxicam. But it is observed that if you use the flunixin maglumine at the rate of 2.2 milligram per kg body weight for 3 to 4 days, so this will also help in preventing the abdominal adhesion formation. So this is also very important. We should use this flumixin maglumin as an analgesia after the C-section in these animals for the prevention of adhesion formation. Now, next is complications. If you will see, the most important complication of the C-section is the adhesion formation. And this, if there is severe adhesion formation, that may cause huge economic loss to the dairy farmers. As I have already told you, nowadays this dairy activity, people are going for this dairy activity for the economic activity, for the income generation purpose. And if there is adhesion formation, that will severely affect the future reproductive potential of the animal, and that causes huge economic loss to the dairy farmers. So this is the most important complication, that is the intra-abdominal adhesion formation. Now, bovines, if you will see, bovine species, they are more prone to adhesion formation. And the reason is that in bovines, there is very low level of plasminogen activators, and there is high level of fibrinolytic inhibitors that favors the adhesion formation within the abdominal cavity. Now, if you will summarize this complications, you can classify these complications into the four categories. First one is the pre-operative complications, operative, intraoperative complications, post-operative complications, and long-term complications of this C-section in bovines. So pre-operative complications are the delayed delivery, anorexia, fetal death, fetal emphysema, forced extraction, fetal abnormality, fetal limb fracture, uterine inertia, and uterine trauma, rupture, severe trauma during the manipulation. And during the intraoperative period, you may notice excessive uterine trauma. So these are some basic principles you have to follow. You have to gently handle all the important tissues or organs of the during the surgical procedure. So if you are not following, if you are not avoiding the basic surgical principles, there may be excessive uterine trauma, and all these conditions may lead to the severe adhesion formation. There may be chances of peritoneal if you are unable to exteriorize properly the uterus from the abdominal cavity. So there may be chances of peritoneal cavity contamination, and that may lead to the peritonitis. And if generalized peritonitis develops, that may lead to the decreases the chances of survival of the dam. Another complication during intraoperative period, you may find there will be trauma to the gastrointestinal tract. There may be excessive trauma to the abdominal wall, inadequate uterine closure due to the uterine tear. That may be one important complication. Then difficulty in exteriorization of fetus. This may be also one important intraoperative complication that we are observing during the C-section procedure. Now, in post-operative, immediate post-operative complications, you can say, you will find, you may observe peritonitis, seroma formation. There may be chances of retention of placenta, metritis, endometritis, skin suture dehiscence, subcutaneous emphysema, straining adhesions, and mastitis, or lastly, the cow or calf death may also occur in immediate post-operative period. But if you see the long-term complications of the C-section, there may be Downer's cow syndrome you may observe. There may be production losses. This is the great loss to the economic dairy farmers. There may be debilitation or debilitated cow is also one complication. There may be increase in the calving service intervals because of the compromise in the future reproductive efficiency of the animal. There may be increased per services per conception. This may be also long-term complications that you may notice if the animals are undergoing the C-section. There may be chances of spontaneous abortion. There may be infertility. So these are some important long-term complications that you may observe in the cases of C-section. In brief, this is the video clip of surgical procedure for the C-section. This is the skin incision, paramedian skin incision. We are following paramedian approach. Now you can see incision on the rectus abdominis muscle. Then this is the blood dissection of the rectus abdominis muscles. Then you can able to see this peritoneum. Now this is opening of peritoneum. Now you can see the gravity uterus is exteriorized out from the abdominal incision, and now we will put the hysterotomy incision for the extraction of the uterus. So incision on the uterus, it is given on the greater curvature of the uterus. You can able to see a sufficiently large incision you have to put over the uterus. Then you can see this is the extraction of the fetus from the uterus. So this is again C-section procedure in a ship. You can see again we are following here in this particular case paramedian approach. You can see this is the incision over the rectus muscles. Then this is the opening of the peritoneum. Now this is the incision over the gravity uterus on the greater curvature. Now this is the closure of the uterine incision, and normally, as I have told you, we are closing the uterine incision in 2 layers. So this is the second layer, and we are trying to invert the first layer so that the suture material should not be exposed. That is very important. And knots also should not be exposed. For that purpose, you can put the buried knots. Now, after completion of the closure of the uterus, this is the cleaning of the uterus. Then we are replacing the uterus inside the abdominal cavity. Then this is the abdominal incision closure or laparotomic incision closure. This is the completion of this repair of the abdominal muscles. So this is the skin suturing, final closure of the abdominal wall. This is the post-operative.